Good morning, everyone. I'm just getting home from a night shift, and I can't stop thinking about this case, and I have to share it with you here. So have a seat. Welcome back to TikTok Med School. The case involves a 5-year-old that was brought in by their parents for complaint of fatigue, body aches, and generalized weakness. They also noticed that the child appeared very pale, and they noticed that the child's urine was very, very dark. The parents also add that the child had what seemed to be an uncomplicated upper respiratory infection about 2 to 3 weeks ago that self-resolved and went away on its own. After that infection resolved, they decided to visit family up in the mountains for a ski trip, and it was during that trip that they noticed that their child was not acting normally. All right, so now you're entering the exam room to examine the child, and immediately you recognize that this is not a normal appearing 5-year-old. They seem very, very lethargic, slow to respond. You notice on the monitor that their heart rate is elevated, and as you get closer, you can appreciate that they do look pale and that the whites of their eyes are yellow or jaundiced. You are concerned that this patient is critical, so you ask your medical team to set up IV access. You make sure that the patient is on a cardiac monitor, and you send off the appropriate blood tests. While you're waiting for those blood tests to come back, you do a secondary assessment on this child, looking for any other clues as to what could be going on. On exam, again, you appreciate that this child is lethargic. They're responding to you appropriately, but again, they're slow to respond. And on exam, they don't have any signs of skin rash, and although they have body aches, they have no focal or specific areas of pain. The parents further add that the patient has no significant past medical history, no significant past surgical history, and the nurse interrupts you because the lab has a critical value to report. The lab wants to let you know that the patient is severely anemic. Their hemoglobin is a 6.0, which is an indication for a blood transfusion. The nurse also wants to let you know that the urine results have come back, and there are signs of blood in this child's urine, but there are no red blood cells. All right, that's all the information that I have for this case to start you off. I'm going to give you some time to take some guesses and think about what you would do next and what could be the cause of this. And when I come back, we'll discuss the diagnosis and treatment. All right, good luck.
Apologies, I was on an extended coffee break. Welcome back, let's start. Last we spoke, we were treating a 5-year-old who was suffering from weakness, generalized body aches, and dark urine. And on exam, we found that child to be tachycardic, or their heart rate was fast. We also noted that they were pale, and the whites of their eyes were yellow or jaundiced. Their labs were abnormal for severe anemia, and their urine had signs of blood in it without any red blood cells. Anemia is always abnormal, especially when it's a child, and the astute lab technician proactively made something called a peripheral blood smear. For context, this is a normal blood smear. The way that it's made is that a small amount of blood is smeared along a glass slide. That slide is then dyed and looked at under a microscope. And we can see normal red blood cells in this photo, and also we can see other cells within the blood, such as neutrophils dyed in blue, purple. And this is what the lab technician found when they created a smear, and they wanted to call and let you know that the child's blood cells are abnormally clumped together. So what could be the cause of this child's anemia? Could it be that they're not creating enough blood cells? For example, children suffering from acute leukemia? But this all happened in a matter of 3 days. They have recent blood tests that were normal, and their other cell lines are within normal range. For example, their white blood cells are normal. Not that that excludes that diagnosis, but it just doesn't quite fit. Could it be that they're losing blood or that they're bleeding? But that's unlikely. The child does not have any signs of bleeding. They weren't in any recent traumatic injury. They don't have any focal or specific areas of pain. And then are they inappropriately breaking down blood? That's still possible, and that would explain the patient's urine. What we're looking at is not blood itself in urine, but the byproducts of when blood is broken down. So you're concerned that this patient is suffering from acute hemolysis. Just to break that word down, heme is blood, and lysis is to break down hemolysis or hemolysis, and you consult the hematologist. Hematology is on the phone, and you explain the patient's history, presentation, their exam, and also their lab findings, and your suspicions of acute hemolysis. They ask for additional labs to be sent to confirm that diagnosis, and thankfully, the tech has kept an additional sample, probably predicting that this outcome was going to happen in the first place. Now hematology is at the bedside with you. They remark on the child's jaundice or their yellowed eyes, consistent with the diagnosis of hemolysis, as bilirubin is a product that exists within blood cells and is released when they are broken down, yielding the yellowish color to the child's eyes. But why is this child suffering from hemolysis? Well, the hematologist makes a note that the smear shows clumping, which is a very important sign. Those red blood cells are doing something called agglutination. They are being bound together by antibodies. Antibodies produced by that child's immune system inappropriately. Now the hematologist is concerned, when exactly did these symptoms start? And you remind her that these symptoms started when the child was visiting family in the mountains. She is concerned about a very rare diagnosis and asks you to hold transfusions until she can rule that out. The specific test? Antibodies to cold. That test was proven positive. This child was suffering from a cold antibody-mediated autoimmune hemolytic anemia. This is an incredibly rare diagnosis that you and I will probably never see again. Let's connect the dots. Let's take some steps back. About 2 to 3 weeks ago, remember the child suffered from an upper respiratory infection. It turns out that that infection was likely secondary to a bacterium called mycoplasma, which commonly causes what we know as walking pneumonia. Blood tests confirmed that this child had antibodies to that mycoplasma bacterium. During that infection, that child developed antibodies that inappropriately attack normal cells. This is the basis of many common causes of autoimmune disease. In this specific disease, those antibodies inappropriately attack red blood cells, and they are activated by cold temperatures. The interesting fact is that it's been found that many of us, approximately 75%, develop antibodies like this from various types of infections, but only very few suffer from actual symptoms and disease. And the temperatures at which this process can start can be as low as 30 degrees Fahrenheit and can be as high as around 50 degrees Fahrenheit. An exposure to cold weather during this autoimmune process can lead to acute hemolysis, or breaking down of blood. This child needed a transfusion, but all products needed to be warmed for treatment. Thankfully, this process is often transient, and your child is able to be admitted to the hospital and receive warm fluids as well as warm blood for their transfusion, and they're able to slowly recover. They were also treated for any remnants of their prior infection. Congratulations, you just diagnosed cold-induced autoimmune hemolytic anemia. All right, let's talk again soon.